towards our normal brain perfusion. To function normally, our brain needs 54 milliliters of blood on 100 grams of brain tissue per minute. When this blood amount decreases, about 50, there is stroke, as you know, and several mechanisms which can result in ischemic stroke. First, it is embolism. When there is embolus, which can occlude artery. Embolus usually most common from hearts, which causes obstruction of or occlusion of cerebral artery. Second mechanism, it is thrombosis. Thrombosis, it is blood clot forms locally within a cerebral vessel due to atherosclerotic changes. Systemic hypoperfusion, for example, when person has myocardial infarction and his systemic blood pressure is extremely reduced, it also can lead to hypoperfusion or ischemic stroke. And cerebral venous sinus thrombosis, when blood clots are formed in the veins which drain our brain, and resulting in venous congestion and hypoxia, which damages brain tissue. So these are main mechanisms of ischemic stroke, or you can say main pathogenetical types, subtypes of ischemic stroke. So as we discussed in first class, there are different subtypes of stroke, large artery stroke, small vessels or lacunar stroke, and cardioembolic infarction. So large arteries, it is arteries which presented in circle of Willis. It is basilar artery, it is internal carotid artery, for example. So these arteries usually most common damage by atherosclerotic changes. Small vessel or lacunar strokes, when there is diabetes, when there is hypertension, it is usually deep branches of middle cerebral artery, anterior cerebral artery, posterior cerebral artery. And cardioembolic infarction, as I already told, most common source of embolism, it is cardiac problems. Most common, it is atrial fibrillation. So hemorrhagic stroke. Hemorrhagic stroke usually occurs when there is a rupture of artery. Usually a rupture of artery occurs when there is aneurysm of artery. When there is artery's wall becomes very thin and very high blood pressure, usually there is no resistance of wall of vessel, and this wall usually tears or ruptures, and the blood which is in artery, it usually leaks into cerebral tissue. So there are different subtypes of hemorrhagic stroke. Intracerebral hemorrhage, intraparenchymal hemorrhage, but usually intracerebral, intraparenchymal is the same, but still they differentiate them. Intraventricular hemorrhage, when blood accumulates within ventricles, and subarachnoid hemorrhage, which characterized by accumulation of blood in subarachnoid space. So hemorrhagic stroke, it is less common type of stroke. Hemorrhagic stroke has little bit different symptoms in onset. When we talk about ischemic stroke, there are usually focal neurological deficit. For example, paralysis or paresis, loss of speech, loss of sensation, loss of praxis, loss of vision. In case of hemorrhagic stroke, here usually brain symptoms such as headache, such as vomiting, dizziness, loss of consciousness, and less common focal neurological deficit. In subarachnoid hemorrhage, usually it is characterized by very severe headache, very intensive headache, which patients usually describe as they never had before. So severe headache and vomiting. Usually they have photophobia. It is increased sensitivity to light. They have severe headache, and they have vomiting. And of course, there will be positive meningeal signs such as nuchal rigidity, such as Kernig sign and Brudzinski sign in subarachnoid hemorrhage, but there will not be any focal brain dysfunction, such as paralysis or paresis, for example. Etiology of hemorrhagic stroke. Previously, we discussed in the first lecture, we discussed about risk factors of stroke. We discussed about modifiable, non-modifiable risk factors. So as you remember, non-modifiable risk factors include race, age, ethnicity, race, age, sex, and heredity. And there was group which is called modifiable risk factor, and there were a lot of risk factors which usually can be changed. So etiology of hemorrhagic stroke, first of all, it is hypertension. Hypertension when there is blood pressure more than 140/90. Cerebral amyloidosis, coagulopathies, anticoagulant therapy, thrombolytic therapy for acute myocardial infarction or acute ischemic stroke, arteriovenous malformation, aneurysms, and other vascular malformations, vasculitis, brain tumors. So all these conditions can be cause of hemorrhagic stroke. Acute management of stroke. Acute management of stroke, as you remember in a previous class, we talked about penumbra, we talked about ischemic core. Ischemic stroke, when it usually occurs, there is ischemic core, it is death tissue, it is death parenchyma, and surrounding it there is penumbra, still metabolically active, still salvageable area, which can be saved if you provide restoration of blood within 3 hours. 3 hours, it is therapeutical window, which is given for doctors to reperfuse less affected area but still active, which is called penumbra. So acute management of stroke. The goal of acute management of patients with stroke, it is stabilization of the patient and complete initial evaluation and assessment, which includes CT scan and laboratory studies within an hour of patient arrival. So for all evaluation assessment, it's given only an hour. So CT scan, it is golden standard for diagnosis of stroke and to differentiate ischemic stroke from hemorrhagic stroke. To differentiate why it is necessary, because to provide thrombolytic therapy. Only for ischemic stroke patients, we give thrombolytic therapy to remove thrombus or embolus, which occludes vessel, which occludes artery. So hypoglycemia and hyperglycemia need to be identified and treated early in the evaluation, because if person has hyperglycemia, it usually gives poor prognosis, leads to poor prognosis, as well as hypoglycemia. And hyperglycemia, it is contraindication for thrombolytic therapy. Hyperthermia, it is also not good prognostic symptom of stroke patients. So we have to manage a hyperthermia by giving patient acetaminophen, supplemental oxygen if needed, and optimal blood pressure. We have to keep optimal blood pressure, but we shouldn't decrease blood pressure extremely. only we can decrease up to 15% of blood pressure to support brain perfusion, because brain perfusion and systemic blood pressure, they are interconnected. The less systemic blood pressure, the less brain perfusion, because in the case of ischemic stroke there is low brain perfusion, there is hypoperfusion, and if we decrease blood pressure extremely, for example up to 120/80, of course it will decrease brain perfusion as well. So we shouldn't extremely decrease blood pressure, only on 15%. So here there is a table, National Institute of Neurological Disorders and Stroke, and Advanced Cardiac Life Support Guidelines. They recommend time for thrombolysis. So time interval due to doctor 10 minutes. So from patient's house to admission to hospital must be about 10 minutes. So you can see it is very short time. Access to neurological expertise 15 minutes. Due to CT scan completion 25 minutes. Due to CT scan interpretation 45 minutes, due to treatment 60 minutes, and totally admission to stroke unit or ICU is in 3 hours after stroke onset. So why 3 hours? Because 3 hours it is therapeutical window which is given to us, to doctors, to treat ischemic stroke, to reperfuse penumbra, to restore blood flow. Penumbra, it is still alive surrounding in ischemic core brain tissue, which is will be alive within 3 hours after stroke onset, and within 3 hours, after 3 hours of stroke onset, it will also become necrotic. That's why only 3 hours is given to provide reperfusion. Of course, it's not available in developing countries. Door to doctor, 10 minutes, not available. Of course, it is this protocol, these guidelines must be followed, but not everywhere there is possibility, because due to many reasons, many causes, and of course in developed countries people survive more, and in developing countries death ratio of course is high. So CT scan should be completed within 25 minutes and interpreted within 45 minutes. Most important test is CT scan. CT scan helps us to differentiate ischemic stroke from hemorrhagic stroke. So CT scan, it is a golden standard for identifying a stroke, and it helps to differentiate ischemic stroke from hemorrhagic stroke. Even if CT scan is negative for hemorrhagic stroke and patient continues to exhibit signs and symptoms of acute ischemic stroke, the medical team should evaluate if patient qualifies for thrombolytic therapy or not. Because sometimes the CT scan can show negative for hemorrhagic stroke, but there is hemorrhage. That's why if CT is negative, doctors must evaluate if patient qualifies for thrombolytic therapy or not. Because thrombolytic therapy given only for ischemic stroke to remove thrombus or embolus. So, next is ischemic stroke treatment and management. Only fibrinolytic agent that has been shown to be beneficial, it is alteplase. It is a recombinant tissue plasminogen activator, which is called alteplase. First of all, we give alteplase, but there are a million of contraindications. We will talk now about them. Then antiplatelet agents, usually American Heart Association and Stroke Association recommend giving aspirin, 325 mg orally. So aspirin within 24-48 hours of ischemic stroke onset. And there is another option. It is also removal of thrombus or embolus, which is called mechanical thrombectomy. Mechanical clot disruption is alternative for patients, for those patients for whom fibrinolysis is ineffective or contraindicated, because there are a lot of category of patients for whom thrombolytic therapy is contraindicated due to, for example, bleeding, due to age, due to some other conditions. So there is mechanical clot removal, or it is called mechanical thrombectomy. So, acute stroke treatment. Of course, airway support and ventilation, supplemental oxygen only if needed to maintain oxygen saturation more than 94%. If there is hyperthermia, so we have to manage it by prescribing antipyretic drugs such as acetaminophen. Treatment of hypoglycemia if blood glucose less than 60 milligrams on deciliter. Or if there is hyperglycemia, we have to lower blood glucose. If there is blood glucose is high, to 180 milligrams on deciliter. It is supportive measures. It does not mean therapy. It is supportive measures. So perfusion of ischemic brain area may require high blood pressure, as I told. Systemic blood pressure shouldn't be decreased extremely because auto-regulation is lost. So BP should not be decreased drastically or extremely except in the following cases. If there are signs of other organ damages, such as if there is signs of aortic dissection, or if there is myocardial infarction, or there is edema, pulmonary edema, or there is encephalopathy, retinal hemorrhages, acute renal failure. Only in these cases, blood pressure can be decreased drastically. So, if there is use of recombinant tissue plasminogen activator or mechanical thrombectomy, so in this case also can be decreased drastically. If blood pressure is more than 220 over 120, to lower blood pressure by 15% in 24 hours after stroke onset is reasonable. Usually we don't decrease blood pressure drastically, not to make condition of patient worse, because patient experiences hypoperfusion, and if systemic blood pressure will be decreased drastically, of course it will lead to same decrease of hypoperfusion, perfusion of brain. So we should decrease blood pressure only by 15%, slowly, not drastically. For patients who are eligible for acute reperfusion therapy, except that blood pressure is more than 185 over 110, blood pressure should be decreased with one of the following. So you can give to your patient Labetalol, nicardipine, or clevidipine. These medications can be given for patients who are eligible for acute reperfusion therapy. Labetalol, nicardipine, clevidipine. So, patients with thrombosis or embolism, with thrombus or embolus, may be treated with one of the following. So it is, first of all, thrombolytic therapy such as tissue plasminogen activator, alteplase, or mechanical thrombectomy, antiplatelet drugs, or anticoagulants. So these three main pharmacological and non-pharmacological methods of treatment of patients with ischemic stroke, thrombotic and embolic ischemic stroke. Aspirin is given in 325 mg dose orally when patient is admitted to hospital. But if there are any contraindications, such as, for example, asthma, aspirin asthma, non-steroidal anti-inflammatory drugs induced asthma or urticaria, then we can give another drug such as warfarin. So there are criteria which exclusion criteria means contraindications when we can't give thrombolytic therapy, when we can't give alteplase or tissue plasminogen activator. These criteria, exclusion criteria, contraindications include the following. First of all, if patient brought to hospital after stroke onset more than 3 hours, of course it is contraindication because there is nothing to save. It's already everything died. I mean, penumbra is already died. There is no metabolically active tissue exist. If from stroke onset 3 hours passed, because only 3 hours we have and patient has to save penumbra. If patient had in his past history intracranial hemorrhage intracranial hemorrhage on CT scan. If patient has intracranial hemorrhage, ischemic stroke, of course, it is first contraindication because we only treat with tissue plasminogen activator ischemic strokes, but never hemorrhagic stroke. If patient has ischemic stroke which involves more than one lobe, it is also contraindication, multilobular stroke. If you suggest subarachnoidal hemorrhage, even your your patient CT is negative, but you suspect there is subarachnoid hemorrhage. For example, nuchal rigidity, very severe headache, patient has no any neurological focal signs. So it is also contraindication because we don't give thrombolytic therapy when there is bleeding. If patient had history of intracranial hemorrhage in his past, it is also contraindication. If patient has intracranial tumor, it is contraindication. If patient had any severe head trauma within past 3 months, it is contraindication. When patient's systolic blood pressure is more than 185 and diastolic blood pressure more than 110, it is also contraindication. If patient had intracranial or spinal surgery within past 3 months, it is contraindication. If patient has any bleeding, gastrointestinal bleeding, urinary tract infection, urinary tract bleeding, any bleeding, nasal bleeding, it is contraindication for alteplase or recombinant tissue plasminogen activator. It is contraindication. When patient's age is more than 85 years old, it is also contraindication. So, gastrointestinal cancer or bleeding within 21 days. If you suspect any bleeding disorder, it is contraindication. If platelet count less than 100,000, it is contraindication. When person used heparin within last 24 hours, when person has coagulopathies, it is contraindication. When you suspect or there is aortic arch dissection, contraindication, and bacterial endocarditis, it is also contraindication for thrombolytic therapy. So you can see a lot of contraindications. And first of all, at this time, therapeutical window, which is 3 hours. Therapeutical window is 3 hours. It means after stroke onset, there is only 3 hours which can save patient's life. Why I'm saying save patient life? Because if stroke area is limited by ischemic core only, of course it usually gives less complication. If 3 hours window is lost and penumbra, which is still salvageable area, also becomes necrotic, of course area of stroke becomes very big, enlarges. And of course this mass effect usually shifts midline structures to opposite side, and it leads to increased intracranial pressure. Brain is compressed, and it is dangerous because of brain herniation, which can lead to momental death. So if you save penumbra, you can decrease complications. You can make prognosis of patient better, because you will save this area and focus of stroke core will be limited. And of course, it usually leads to better prognosis, less complications, and first of all, you can save patient's life. But there are a lot of contraindications for thrombolytic therapy. 3 hours given because usually this surrounding area of infarction core, it is still alive within 3 hours. After 3 hours, it usually dies. Dies, it means apoptosis, necrosis. That's why it is called therapeutical window, when we can do CT scan. First of all, we can admit patient, we can do CT scan, we interpret CT scan image, and we provide therapy. Other contraindications for thrombolytic therapy, it is rapidly decreasing symptoms. It is major surgery or serious trauma in the past 14 days. If patient had urinary tract hemorrhage in the past 21 days. If in the stroke onset, patient had seizures, it is also contraindication. If woman is pregnant, it is also contraindication. If patient had the acute myocardial infarction in the past 3 months, it is also contraindication for thrombolytic therapy. Recombinant tissue plasminogen activator, alteplase, can be used for patients with acute ischemic stroke up to 3 hours after symptoms onset if there are no contraindications. Before treatment with alteplase, the following are required. Brain hemorrhage must be excluded. Systolic blood pressure must be less than 185. Diastolic blood pressure must be less than 110. Blood glucose must be more than 50 milligrams on deciliter. Pressure should be less than 185. Diastolic blood pressure should be less than 110. Blood glucose must be more than 50 mg on deciliter. Antihypertensive drugs may be given to patient. Blood pressure should be kept less than 180 over 105 at least 24 hours after treatment with tissue plasminogen activator. Dose of alteplase is 0.0 milligram on 1 kg of body weight IV. Maximum dose is 90 milligrams. Usually 10% of dose is given by IV injection over 1 minute. So it is rapid injection over 1 minute. And remain dose is about 90% of dose is given over 60 minutes. So 10% of dose given over 1 minute and rest of dose given within 60 minutes. So slowly. 0.9 mg on kg of body weight IV. 10% of dose is given by IV injection within a minute, over a minute. And the rest of dose is given over 60 minutes. Of course, we have to monitor vital signs. Anticoagulants and antiplatelet drugs shouldn't be used within 24 hours after treatment with after treatment with tissue plasminogen activator. Oral antiplatelet drugs. What drugs we can give? Oral antiplatelet drugs are used in acute ischemic stroke treatment. Aspirin from 100 to 325 mg within 48 hours of stroke onset. Dual antiplatelet therapy. We can give 2 drugs together, aspirin and clopidogrel. Aspirin is about 300 to 600 mg orally once, is given once. Then 75 mg orally once a day. Within 24 hours of stroke onset for patients at high risk of transient ischemic attack. When ABCD2 score more or is about 4, or patients have minor stroke. Now we will talk what is ABCD2 score. So oral antiplatelet drugs can be given as treatment for acute ischemic stroke. It is aspirin or dual therapy, aspirin and clopidogrel. We can give patients who have stroke. We can give patients who have at high risk of transient ischemic attack. What is transient ischemic attack? It is a condition which is resembles stroke, which is similar to stroke, but which is reversible. Symptoms usually resolve within 24 hours or less than 24 hours or within an hour. And minor stroke. Aspirin given within 84 hours reduces the risk of early recurrent stroke and death. As we know, stroke has tendency to repeat. And of course, recurrent stroke, it is very dangerous condition because if you saved patients alive, so no one knows what will happen next time. That's why we usually, there is secondary prevention of stroke, which usually treatment of individuals who have already had a stroke. And what is ABCD2 score? ABCD2 score is calculating by summarizing the following. A, it is age. If patient's age is about 60 or more than 60, it is 1. B, it's for blood pressure. Systolic blood pressure is more than 140 or diastolic blood pressure is more than 90. It is also 1. C, it is for clinical features. Weakness, it is 2. Speech disturbance without weakness, it is 1. Weakness, it means paresis. Paresis, it is partial loss of movement. D, it is for transient ischemic attack duration. If it lasts more than 60 minutes, it is 2. If it lasts from 10 to 59 minutes, it is 1. If it lasts in less than 10 minutes, it is 0. And D2, it is for diabetes. If patient has diabetes, it is 1. So we have to summarize, we have to add all this score, and there will be final score. So aspirin given to patients whose ABCD2 score more than 4. More than 4. Is 4 or more than 4. Risk of stroke within 2 days based on the ABCD2 score is about. For a score of 6 to 7, risk of stroke is 8%. For a score of 4 to 5, risk of stroke is 4%. For a score of 0 to 3, risk of stroke is 1%. So the more score on ABCD2, the more risk patients have. The less score, the less risk of stroke. If patients have had transient ischemic attack or minor stroke, clopidogrel plus aspirin given within 24 hours of symptoms onset. And we have to continue for 21 days. It usually appears more effective than only aspirin for reducing risk of stroke in the first 90 days. And it doesn't increase risk of hemorrhage. So we give patients who had TIA or transient ischemic attack or minor stroke, we give dual therapy such as clopidogrel and aspirin within 24 hours of symptoms onset, and we continue for 21 days because it usually more effective than only aspirin, and it reduces risk of stroke in the first 90 days, and it doesn't increase any risk of hemorrhage. Long-term stroke treatment. Of course, we have to manage hyperglycemia. We have to control hyperglycemia and fever. Because hyperglycemia and fever usually lead to poor prognosis. If we have to screen for dysphagia, it is difficulty to swallow before patients begin eating, drinking, or receiving oral drugs. Of course, should be done by speech-language pathologist, not pathologist, therapist, or other trained health care practitioner. Enteral nutrition, if needed, should be started within 7 days of admission after acute stroke onset. Intermittent pneumatic compression for deep venous thrombosis prophylaxis is recommended for immobile stroke patients without contraindications. Low molecular weight heparin may be given to immobile stroke patients without contraindications. And measures to prevent pressure ulcers are started early. Extracranial carotid endarterectomy or stenting. Extracranial carotid endarterectomy or stenting, it is indicated for patients with recent non-disabling submaximal stroke attributed to an ipsilateral carotid obstruction of 70 to 92 of arterial lumen, or to an ulcerated plaque if life expectancy is at least 5 years. In other symptomatic patients, endarterectomy or stenting with antiplatelet therapy is indicated for carotid obstruction of more than 60% with or without ulceration if life expectancy is at least 5 years. This procedure should be done by surgeons and interventionists who have a successful record with the procedure. It means morbidity and mortality rate of less than 3% in the hospital where it will be done. Oral antiplatelet drugs are used to prevent subsequent non-cardioembolic, atherothrombotic, lacunar cryptogenic strokes. Secondary prevention. Oral antiplatelet drugs are used as a secondary prevention. So what we can give as oral antiplatelet drugs? Aspirin, clopidogrel, or combination product aspirin and dipyridamole. Aspirin and dipyridamole twice a day. Oral anticoagulants we can give, you can read about it later. Statins are given as treatment of dyslipidemia. We usually give statins, but always if it's a primary prophylaxis, it is prophylaxis of stroke for patients, treatment of patients who have no history of stroke. First of all, we have to recommend them to keep dieting, so to review their diet, to decrease fatty, oily products, to decrease junk food, to stop smoking, to increase physical activity, to change their lifestyle, and only after we can prescribe statins. Hemorrhagic stroke treatment and management. Treatment and management of patients with acute intracerebral hemorrhage depends on the cause and severity of bleeding. Basic life support as well as control of bleeding, seizures, blood pressure, intracranial pressure are critical. Medications used in the treatment of acute stroke include the following: anticonvulsants to prevent seizure recurrence, because very many cases of stroke are characterized by seizures. And as you know, seizures usually is contraindications for, if it's ischemic stroke, it is contraindication for thrombolytic therapy. Hemorrhagic stroke, we don't treat by thrombolytic agents. So in hemorrhagic stroke, if patient has seizures, we give anticonvulsant medications. To reduce blood pressure, we give antihypertensive drugs. To decrease intracranial pressure, we give osmotic diuretics. Invasive therapy. A potential treatment for hemorrhagic stroke is surgical evacuation or removal of hematoma. Hematoma, it is blood accumulation within brain tissue. So, first of all, we have to evacuate or remove this blood. Surgery undertaken within 8 hours of ictus. Ictus, it is onset. Volume of hematoma, 20-50 milliliters. Glasgow Coma Scale score 9-12. Glasgow Coma Scale, it is scale which helps us to assess level of consciousness of patient. Total score is 15. There are 3 criteria: eye opening, motor response, and verbal response. So we usually assess patient's level of consciousness by summarizing 3 criteria score. And if patient is fully conscious, as we are now, it is 15. 9-12, it is a condition which is called moderate. Less than 9, it is severe. So Glasgow Coma Scale score 9-12, it is moderate severity of brain injury. In this case, it is hemorrhagic stroke. Patient's age is 50-69 years old. So endovascular treatment of aneurysms, ventriculostomy, placement of intraventricular catheter for cerebral fluid drainage. These manipulations or invasive therapy are used in treatment of hemorrhagic stroke. That's all. It was last slide. Yeah.